Cool. All right. So diving right in, the objectives for everyone by the end of this, I'm hoping that we will be able to describe the classifications of pain, recall the assessments useful in pain management, recognize the appropriate pain management pharmacotherapy depending on a patient's current pain level, recognize that I am going to talk about other modalities. The pharmacist being that I might lean heavily towards pharmacotherapy just because pharmacotherapy is still a pretty solid staple in pain management. So, and I guess I'm going to make sure that moving forward that you all can leave here knowing whether or not a medicine is appropriate for a patient for pain management. And then identify resources which can be used for aiding with pain management. So it's really hard to understand how much pain affects everyone. You know, it's very easy to sympathize with. There is a pretty high prevalence of chronic pain. You know, sometimes with pain in general, it can be just age related. The longer we've been alive, the more joints go under stress, the more likelihood you have chance of injury. And so it is pretty prevalent in those who are older. And it is known to be of a higher prevalence in those who are older compared to the younger population. It's hard to say how many patients, chronic pain, I guess, exists in maybe up to 50% of older adults. Again, it might depend on the type of pain. It might depend on the location of the pain, but it's fair to say that chronic pain is present in a large portion of those who are older. And another reason I can sit back and say that we all recognize that pain management and, from a condition perspective, whether it should or should not be managed, I argue that it should be. And one striking reason is chronic pain is actually a known risk factor for premature death. Now, it's interesting, like we don't know, is it from the pain itself? Is it from the pathology of the underlying pain? So for example, if you have cancer pain, is it, just because you had pain, is that the reason that you had this premature death? And Frank, was it the pharmacology we used to try to manage the pain? Uncertain. But knowing that a patient has chronic pain, you can argue premature death is potentially there for them, or on the table for them. Trying to understand how pain works is still a very difficult beast, if you will. I can sit back and tell you that it's an interplay between our nervous and immune system. It can be within the peripheral nervous system, which is the nerves away from the spinal cord and away from the brain. The nerves that are responsible for us to feel something, that would be considered the peripheral nervous system, and also the central nervous system, which would be the brain and the spinal cord. So there's an interplay between these nervous systems and the immune system. And the thing we need to recognize is pain is actually normal. Pain is actually a protective, evolutionary process. The issue is it can also be pathophysiologic and harmful. We can actually base this on different processes that are being found biologically, and the pain itself can be impacted by other influencers, which can even be external, such as social determinants. To think about pain, we really have to understand the types of pain. Now, there are quite a significant amount of breakdowns of classification of pain. I wanted to try to focus on some that are more prevalent or more you're used to seeing. Adaptive pain, if you ever hear that, that is the normal pain that you expect out of normal physiology. We touched something that was hot and it hurt, that's expected. That would be considered adaptive pain. Now, nociceptive pain is the subset of when I develop pain from a noxious stimulus. So going back to that whole hot burner, touching something that was warm, that would be considered nociceptive adaptive pain because there was a noxious stimulus to cause it. This again is it's pretty much found in almost every living organism. That's maybe an overstatement, but the long story short is it's been around for forever. We've evolved, we've needed it. It's meant to protect us from actual or potential injury. Now, there's a subset of inflammatory pain, which is the immune system's response to pain. That's more useful actually in warning the tissues next to the tissue. So then, I hurt the 5 receptors that are on my finger. So then all of a sudden the 5 receptors that are around it, they can also experience some element of this pain due to the immune system causing some inflammation. I want to take a step away. Again, we're going to still dive and talk about the classifications and kind of recollect the physiology of pain. And whenever we talk about pain stimulus, or sorry, pain transmission, we start with a stimulus. And at some point, something occurs to then lead to what's called transduction. I turn the stimulus into something internal that the receptors can then conduct, or at least send the message and start the signal. Conduction occurs from the site of injury into the spinal cord. From the spinal cord, it gets transmitted up through the spinal cord until we hit the brain, which is where the perception of the pain occurs. Now, that we're not done there, because afterwards the brain and other systems can actually modulate this initial signal transduction, conduction, and transmission, and change how the pain is felt. You can actually have chemicals secreted that then could amplify the pain signal. You have different molecules that could be secreted that would make the pain lessened. And the easiest one I can think of here too is endorphins. And when endorphins are released, that actually can help lessen the pain stimulus, even though the same stimulus could be occurring, but all of a sudden the pain does not feel as intense. That is modulation from endorphins, as an example. So why it's important to understand the normal processes of pain, and again, a very abbreviated version, is because that's where we can classify the non-good pain, if you will, for lack of better terms. Maladaptive pain or pathologic pain is whenever you have pain that's disengaged from that noxious stimulus. We could have damage anywhere along that pathway, minus the fact that the stimulus is not present. Now, this, again, can be from within the peripheral nervous system. This could be within the central nervous system. It could be within both. A lot of times it's from actual damage somewhere. Subsets of this can be broken down into neuropathic pain, where there's damage to the peripheral nervous system or the central nervous system itself. To break down examples, I gave a few, just a very subset few. Postherpetic neuralgia, which is the pain you experience after shingles, is actually peripheral nervous system neuropathic pain. Diabetic neuropathy and chemotherapy-induced neuropathy. Now, I think chemotherapy-induced neuropathy is the easiest way for me to explain how pain can be disconnected from a noxious stimulus. Sure, chemotherapy came in, tried to kill the cancer. It now killed the nerves in your finger. The chemotherapy is now done. It is gone. It is wiped away. You have no more chemotherapy in you, but the long-standing damage to these peripheral nerve fibers are eliciting now a constant or a different signal, which is damaged, and it's now leading to the perception of the pain. Examples of central nervous system neuropathic pain could be considered like multiple sclerosis or a stroke, where again, the stroke might have damaged the brain. The stroke is no longer happening, but the brain is now damaged and you are perceiving pain, even though I no longer have the noxious stimulus present. Central adaptive or maladaptive pain is a bit tougher, where there's actually maybe issues more with the pain processing itself. That's more like when you have hypersensitivity. Examples of that would be fibromyalgia. Is an example of this centralized maladaptive pain. Further classification can be broken down to acute or chronic, where acute pain is short-term. There usually is a reason, like a stimulus. I punched you in the arm. That lasts less than 30 days is historically our classification of acute pain. Depending on who you talk to, depends on where you can draw that line at where acute pain and chronic pain exists. But chronic pain is now where it's long-standing. It's usually a maladaptive pain, where the stimulus is now removed, and now we have some sort of pathologic problem. This may, again, the books, depends on who you talk to, maybe 3 months. It could be shorter or longer, but historically, if it's been at least 3 months, you can consider chronic pain. You can divide this chronic pain even further. Is it chronic neuropathic pain? Is it chronic neuroceptive pain? Centralized? It could be something all of the above. It could be continuous. It could be just episodic, like with a migraine, if you think of it that way. I did throw cancer pain in here just as a reminder that it is a type of pain that, again, could be related to the disease that is cancer, could be related to the treatment procedures, acute or chronic. It's kind of the pain that, like, where all the idea of chronic pain management tended to originate from. because it was well known that these are individuals that have significant pain and a reason to be in pain. The last two kind of definitions, I guess, for you to recognize is hyperalgesia, which is when you have an exaggerated response to a stimulus. Again, I punched you in the arm, but it felt like I shot you with a weapon, right? That is an exaggerated painful response. Allodynia, I was always taught, is it's pain from a non-painful stimulus. So the example being is if I just poked you and it felt like I punched you. We have our basis of the thought process of pain in terms of getting our bearings with type of pain, right? Now let's talk about the assessment, which is crucial in pain management in anyone, especially those who are older. A comprehensive assessment is key. You have to figure out, if you can, why it's happening. Descriptors of the pain help understand providers or anybody else what is going on and what might be best therapies for them. The piece that matters most in everybody, but I argue matters the most in the older population, is how much is this impacting your ability to function? How much is this impacting your ability to do these activities, which then also impacts your quality of life? I will plug that pain management is very, very, very important, and more importantly, very much a team-based approach in many cases. No one person can do it. There really is, given that there's some different subsets of reasons why pain could exist and how to fix it, it's best to get these other individuals involved with the team as possible. You need to recognize that your bias itself as an evaluator can be at play. You know, it's easy to look at an 80 or 90-year-old individual and have even extra what you might think is empathy towards them, when in reality you might be overselling how bad this pain is for them because of your implicit bias. Don't forget about bias. Leaving here, if you guys now know the difference between symptoms and signs, then we'll be good. Symptoms are what a patient describes. So forgive me on that. Symptoms would be the descriptors of pain. That would be sharp pain, dull pain, achy pain, tingling, shooting, fiery, you name it. However a patient describes their pain are the known symptoms, and that is very useful to know what is going on and how to best treat them. The signs are where things get a bit different. Signs are what others can find and see on the patient. An example of a sign would be blood pressure and heart rate. Acute pain usually has signs to it. If you need to remember that acute pain is a normal process that's meant to protect us. When you're in acute pain, I expect things like a high blood pressure and high heart rate. The thing is, with chronic pain, you've had this pain for so long, the body can compensate, and realistically, you would have no clue from a signs perspective that they are in pain. You may notice some signs in terms of other comorbid conditions, where depression, anxiety, insomnia, the pain is now leading to insomnia. That would be a way to argue that chronic pain, these are some of the signs, I guess, of chronic pain. But don't be surprised if you don't see the typical signs that you would expect or think about with pain in somebody who's in chronic pain. I did put it on here to be all-encompassing. The laboratory tests very rarely are done in pain management. Pain is subjective. It's up to the individual to tell you. Yeah, sure, there's some labs we could do that may or may not rule out certain etiologies. I'll give an example, vitamin B12. Vitamin B12 is a known vitamin needed for nerve health. So you could consider getting that to try to determine that, if your vitamin B12 is deficient, then there's a chance I could resolve this pain by just fixing your deficiency. But at the end of the day, labs are very rarely, very seldomly needed and used in pain management. The assessments that we're all used to is trying to have a patient explain how severe the pain is to you, the observer. There's many different scales, right? We're used to probably the 0 through 10 number scale. 0 if there's no pain, 10 is the worst pain ever. There's a whole other pain scales, is again where if somebody said they're in moderate pain, that might equate to a 4 out of 5 on the number scale. The Wong-Baker FACES scale is very, very, very still validated. Might have better place in kids, but it would still work. At the end of the day, there's some sort of assessment scale that you should use to help rate the pain for a patient. we can summarize pain assessment realistically into this PQRST model, where P would stand for provocative or palliative. In other words, what makes it better and what makes it worse. Q being the quality or descriptors of the pain, the burning, stabbing, dull, you name it. R is the regions where it's located. You know, if I know that it is affecting your right hand only, that helps me understand what's going on. Severity is you're talking about the different number scales. And then lastly is timing. So when does the pain occur? How long does it occur? If you can think of the PQRST every time you are trying to assess a patient for pain, you are in a very good place. We have our assessments done, so let's shift into pain management of pain, right? Now, one thing to recognize is pain management for the older adults tends to mimic your younger adults as well, with a couple little caveats. The one thing that matters no matter what is we need to find goals. Set those goals early. Understand what the patient's goal is, because that will help you know how to treat them and maybe how to not treat them. This balance of finding relief, improvement, and adverse events is really at play. You know, I could make somebody's pain go away if you drug them up, and that's not necessarily the goal for everybody. You know, maybe their goal is actually just to say, I want a 3 or 4 out of 10 out of pain so I could be able to like walk every day. That's where you have this realistic and measurable goal. You know, no offense to a patient, if they want 0 pain, but they're dealing with something that has definitive pathology, you're not going to be able to make that pain go away. And I've told a patient many a time, like realistically, I'm like, I know you just said 0 out of 10 is what you want. We can't do that. Like that is not possible. And you'd be surprised. Patients might tell you, look, I'm okay with having a 3 out of 10 pain every day, because they're aware and they know that they're going to be in pain the rest of their life too, unfortunately. Creating those goals matter. Overall consideration, though, is non-pharmacologic is preferred. I think we would kind of get that. You can use both, though. Don't ever forget that you could do non-pharm with pharmacologic. And this is the caveat that goes with the older adults. When using pharmacotherapy, you want to use the lowest effective dose for the shortest duration possible. And that's just because older adults are more susceptible to side effects and adverse events. The sad thing is most of the adverse events of our pain management therapies, pharmacotherapy, lead to other complications like falls. So, hooray, your pain went away until I made you fall and break a hip, and now you're in more pain. So, recognize that older adults are more susceptible to side effects. The simplistic algorithm, if you will, that I have broken down is start with non-pharmacologic options first, which we'll go into depth a little bit later. And then you break down the options based on their pain, if it's mild, moderate, or severe, where mild is a 1 through 3, moderate is 4 out of 7, and severe is 8 out of 10. You have to look at other things too, where how much of impairment is being done. Whether there is minimal impairment up to the fact that your quality of life is being diminished. Your options is to use step 1, which is non-opioid options, if you have mild pain. Now, if you have moderate pain, you should try step 1 realistically. But if moderate pain is not being managed with step 1 options, go to step 2, which is your short-acting opioids or adjuvant medications. And then if you're having severe pain, realistically, you should try to fix it with step 2 options. But if you can't do that, you've inevitably earned opioids. And this is where it's not a no, you don't use opioids in older individuals. You just have to make sure you use them effectively and safely. You can consider minimally invasive or invasive procedures for moderate or severe pain. I say that because these procedures, they may or may not work for certain people. They may or may not work for every pain type. Recognize that there are procedures that can be done. We reserve them for moderate or severe pain, and we usually reserve that when your other options don't work or the other options aren't safe. Overall, non-pharmacologic management can be summed up in this slide. I will admit we could go into major depth about all of these other options. I focused on the pharmacology, being the pharmacist that I am, not to discredit the non-pharm options, because I believe that non-pharm is one of the most important things you can do for pain management. The first being is education. Making sure that a patient is aware of their situation, understanding their goals, and educating them on the realisticness of pain management and how to effectively make it better without medications is crucial. It can be broken down into self-management, self-administered, non-self-administered, and then also kind of exercise and physical therapy. Your self-management is these cognitive, between cognitive behavioral therapy, acceptance and commitment therapy, which is the argument of going through different strategies to be able to say, I am in fact in chronic pain. I will be in chronic pain for the rest of my life, but learning how to not let it take over. Stress management and biofeedback are other ways that things that a patient can do on their own to kind of help mentally deal with their pain coping. Self-administered options would be like heat or cold. You've got music. You've got the TENS unit, which are these the units that can kind of like provide electrical current that can help offset the pain. Would be examples of self-administered options. Your non-self-administered would be things like massage, acupuncture, and skeletal manipulations, kind of like with chiropractors. Lastly, being exercise, which would be walking, water therapy, yoga, tai chi. Those are always, if you can find ways to incorporate some or all of these, or find ones that are going to be more beneficial for a patient depending on their pain or another, you almost always want to figure out how to incorporate non-pharmacologic in every patient if you can. These can still be continued even if you're using pharmacologic options. Maybe these non-pharmacologic options allow for less pharmacologic meds being used, right? At the end of the day, do not forget that these exist and should be done and reassessed and reevaluated for everyone, including older adults. Now, a bulk of this is going to be talking about the pharmacologic options. I'm not expecting you to leave here memorizing all of them. I'm trying to leave here with Pearl's kind of thought processes. If you end up dealing with an individual who's in chronic pain, my piece to you is hopefully you can learn knowing whether these are an effective or an option that should be considered, or the questions you should ask to be able to make sure a patient's pain is being managed appropriately with medication. If you remember, step 1 was resolved for this mild pain. Your options include acetaminophen, counter irritants, topical analgesics, topical NSAIDs or non-steroidal anti-inflammatory drugs, and then the oral NSAIDs instead of topical. Acetaminophen is, when in doubt, our first-line agent if you can use it. It's usually well tolerated, usually safe. Now, I say usually safe does not imply that it is safe in everybody. So an example would be alcoholics or people who use frequent alcohol or drink alcohol, and anybody in liver impairment. So recognize that while Tylenol, acetaminophen is most likely what we'll use first, it's not always safe in everyone. It's also very easy to overdo Tylenol. You could be taking the max amount of acetaminophen, but they threw acetaminophen in another over-the-counter product like NyQuil, and you've now effectively taken too much. So it is very easy to overdo acetaminophen on accident. The usual dose is, it's still in heated contention. If you're going to use it chronically, then you would want to really stick to 3,000 per day. There's arguments in acute pain that you could maybe consider 4,000. But when in doubt, 3,000 is probably a safe maximum limit per day. But if somebody does have liver impairment, the max is now 2,000. So you just need to keep in mind, if they're using 2,000 of acetaminophen and then they take that NyQuil, congratulations, they've now just pushed into too much. But when in doubt, acetaminophen is more than likely what you will start with any geriatric older patient. The counter irritants, this is like your Icy Hot, your Bengay, the things that can kind of, again, go against the it's hard to explain how these tend to work, but all of us know exactly the feeling that these generate, and they may or may not, that feeling could help offset some of the pain that an individual is feeling. They are preferred options in geriatric patients, and again, because they are topical, they tend to be effective. They really have minimal side effects in most cases. They are very good in localized musculoskeletal pain and minor pain. Arthritis, there is data, but it tends to be the more joints you got to use, maybe the less effective it's going to be. Doesn't mean you can't do it, just realistically try it. There's many different options in terms of formulation. It does come in a patch, which depends on which option you get, right? But that patch might actually stay on better and help an individual. But know that because of this over-the-counter formulation, they're doing whatever they can to set themselves aside to pick one over the other. The only product that you can consider is a little bit weirder is anything that contains this methyl salicylate. If you are using it too much, if you are in fact using it over large areas of the body can absorb, even though you absorb a little bit, when you put on a lot of it over your whole body, that little bit turns into a lot bit. And so you do need to watch that. But again, seldomly is that a problem. Do know that if you have a patient who's like, yep, I'm pretty much bathing in icy hot 3 times a day, then all of a sudden, if it's a methyl salicylate product, you could be running into issues. Lastly, too, it should be known that to avoid open wounds, your eyes, your genital areas that are much more sensitive to these products. The topical analgesics is a bit different. Capsaicin and lidocaine, they work differently, but at the end of the day, they're trying to overall inhibit pain signals being sent. They are also preferred options in geriatric patients. There is more data actually in these agents comparatively. There is data in particular in neuropathic pain, like diabetic neuropathy. The thing is, they can be a little bit intense for certain people. So you do got to be careful if you're going to be applying it. The hands do need to be washed. Capsaicin is actually the molecule that's found in your chili peppers. And so if you think about that, like if I rub my hand after touching a chili, that would hurt. The exact same thing would happen in the case if you're using things like capsaicin. One of the negative complications, I shouldn't say complications, but one of the negative caveats to capsaicin is it might take weeks to months to be effective. As somebody who's used capsaicin myself, you feel pretty warm, but in order for the chronic pain management that we're hoping for, it might take weeks or months to be effective. So even though it's still a preferred option in the geriatric patient, it might have moments where it's not as ideal. The only topical NSAID that exists right now is diclofenac gel, which is also called Voltaren. It is over the counter now. I want to point out that it is actually just as effective as oral NSAIDs. There's less side effects than oral NSAIDs. So like at the end of the day, it's more preferred to pick it first if you can. The data is strongest in hand and knee arthritis. Now, that doesn't mean you can't use it. I would argue that you could attempt to use it in low back pain. You could attempt to use it in shoulder pain. It might not be as effective as because the data is not as strong. It should be a safer option compared to oral NSAIDs. There is still some absorptions, so you may still need to monitor, but at the end of the day, it is a overall safer option compared to oral NSAIDs is what I'm hoping you leave here with. As a final segue into the oral NSAIDs, I didn't list any here, but that would be your ibuprofen, your naproxen, Advil, and Aleve as examples. If a patient tells you what is this for and they say this is an NSAID, you've now got in your head what that is. The other option is this, what's called a COX-2 inhibitor. This is celecoxib. The brand name is Celebrex. These meds ultimately inhibit intermediates that cause inflammation. The problem is some of these intermediates, the prostaglandins, also have other protective functions, such as lining the stomach to protect you from acid, impacting blood flow through the kidney. And so if I inhibit the prostaglandins that reduce inflammation, I also inhibit some of these other protective pieces. So that's why they're not as ideal, because they do come with more side effects compared to everything we've just listed in step 1. As a positive, though, the COX-2 inhibitor inhibits the prostaglandins of inflammation only. So this whole kidney problem, this whole stomach lining problem is not there. The only issue is you end up getting a buildup of intermediates that can increase cardiovascular events. So hooray, your pain is better, but I just gave you a heart attack. So this is where it not to oversell the dangers of this med and not try to undersell it either. It just goes to show that every medicine, for every benefit, there is a risk to it. These meds are very useful in acute pain or flares for certain conditions where you need it for a short period of time. Very seldomly do you want to use it for chronic pain. You can, don't get me wrong, there's just high risk. Those risks mostly being the gastric ulcers. Patients can have a higher likelihood of having stomach ulcers if we are using NSAIDs. This doesn't count for the Celebrex. Now, you sit back here and you say, well, guess what? I have meds that can prevent ulcers. That's fine. Some of those meds that prevent ulcers also have their own risks in the older population, such as osteoporosis, intestinal infections, and kidney disease. So my question comes is it worth it to use the NSAID if I have to use another medicine on top of it to prevent the problem that can cause other issues? Leaving here, I don't want you to be anti-NSAID. What I want you to be is I want you to question the use of NSAID. Question if we're using it at high doses. Question if we're using it for a long duration. All of a sudden, this med, which is beneficial, has a chance to become more risky than it is beneficial. It is still a step 1 option for mild pain. This is where we shift into step 2 options, which is your short-acting opioids. Not all of them, we'll talk. There are adjuvants, which have different classifications, which we'll talk about there. And then I'm throwing it in there too, because the cannabinoid options are listed for geriatric pain management in certain subsets, in particular in the moderate pain group. Of the short-acting opioids, I have 3 listed because there are many different short-acting opioids. There are some that maybe have more caveats and more risks. And so that's where if you're going to consider a short-acting opioid in somebody who's older, it would be more advised to consider one of these 3 first. They're very much only for infrequent pain or acute pain, albeit some individuals who go into chronic pain might still be using this. You have to keep in mind the benefit is much more in acute pain. The other piece I want to remind you of is some of these products also contain Tylenol and ibuprofen within it. So if a patient says, yep, I take this breakthrough medicine 4 times a day, there are certain ones that actually will contain Tylenol. So you have to add that to my daily Tylenol use and making sure you're not overdoing Tylenol. I do want to point out that there are a lot of individuals that will try to say, well, if I use tramadol, that is what we call a weak opioid, right? It is supposed to be less intense. I do want to point out there's been multiple studies done. Tramadol does increase the likelihood of seizures, does increase the likelihood of orthostatic blood pressure lowering and causing balance and fall risk there too. So it's not without harm. There are studies that were shown. If we use tramadol over NSAIDs, there was a higher risk of hip fracture compared to NSAIDs or codeine. So congratulations, you're not in pain, but I caused a hip fracture. There's a higher mortality in the use of tramadol compared to NSAIDs. So going back to our NSAID option, I'd rather use an NSAID over tramadol if it means you're going to live. There is a higher all-cause mortality, cardiovascular events, and fractures compared to codeine, which is another type of opioid. So the concern that I'm laying in front of you again is not that you can't use tramadol. I do have a provider here that says you should call it tramadont. I believe that it means that it's, quote, not a safe option just because we call it a weak opioid. It is still an option to consider. Don't write it off as risk-free. It's still considered an option that you would want to use in somebody with moderate pain. It may or may not be more beneficial for certain individuals. Long story short, if you are in a moderate pain situation where you need to consider a short-acting opioid, your options are hydrocodone, oxycodone, or tramadol, preferably. The other adjuvants listed, I'm not, again, expecting memorization of some of these drugs, the carbamazepine, gabapentin, and pregabalin. The reason I'm throwing these on here too is these meds are very beneficial in neuropathic pain. So if somebody happens to have moderate neuropathic pain, this adjuvant may actually be just as good, if not better, than the use of the short-acting opioids. The geriatric patient population is very prone to side effects from these drugs. The most common side effects being sedation and drowsiness. And as you can see, if somebody is sedated and or overly drowsy, we increase the likelihood of a fall. Therefore, was it worth it to use this drug? Could be worth it, but it's still risky. Carbamazepine has mood stabilization properties. So if there's individuals with mood problems, you could consider that as another positive, but there's a lot of drug interactions. Gabapentin does, in fact, have different doses depending on kidney function. So if you have a patient who has reduced kidney function, gabapentin will be more effective, increasing the likelihood of falls. So another piece to remember here. Out of all the 3 of them, the pregabalin is maybe the one that's the, quote, best one to use, but I use best lightly because it doesn't mean it's without side effects. It just means it might be the least sedating. The other caveat that I did want to say is any of these options, in particular the gabapentin and the pregabalin, when you use these with opioids, you're more likely to have negative outcomes compared to if you just use an opioid alone. They do, in fact, have compounding effects when used together. So as a positive, they could be more beneficial to be used together, but there is a high likelihood of the respiratory depression, a lot of the negatives you associate with opioids when you use this with them. This one's a bit bulky, I'm not going to lie, and I'll try to make it as simple as possible. We do have some antidepressants that can be used for pain. The positive is these antidepressants actually benefit neuropathic and chronic pain, musculoskeletal pain, forgive me. The TCAs, or the tricyclic antidepressants, they also have some data in migraine, tension headaches, and arthritis. So these antidepressants may or may not actually be useful in a vast majority of your older patients, but there are still some caveats. The TCAs are known to have negative side effects in the older patient. I have them listed there between orthostatic, low blood pressure, sedation, heart arrhythmias. You'll hear anticholinergic side effects thrown around. These are side effects which cause dry mouth, dry eyes, constipation, urinary retention, things that when they occur can be issues for older individuals. They're much easier to occur in older individuals using TCAs. And I did list 2 preferred TCAs out of all of them. Again, they are the least likelihood of causing side effects, desipramine and nortriptyline. My argument to that is TCAs are very high side effect burden, but they work. Duloxetine out of this group is the most preferred one. And so if you really want to consider using an antidepressant or suggesting an antidepressant for somebody, duloxetine would be a good one. Venlafaxine ER does work, but it takes higher doses to work. And once somebody's on venlafaxine, I can tell you in practice, it's hard to get them off. And milnacipran is actually used. There is a higher likelihood of cardiac side effects. So at the end of the day, sure, I might be able to help somebody's mood and their pain. This would be reserved again for patients who are in moderate pain because they are not without risk. Other adjuvants to consider are corticosteroids. They're very useful if you have inflammatory pain and these acute flares. There are injections which could be done to localize, give the steroid to a specific location. The issue is there's a lot of side effects, especially when you use them long-term and at higher doses. You know, I'm listed there too. I can tell from an older geriatric patient perspective, the altered mental status happens way more frequently than you think, especially in those who are older. The immune system can get weakened, and you can also have gastric ulcers. You know, you really can offset normal physiology if you use a steroid for too long. And so that's why it's very useful to be used in acute pain. If you happen to see somebody on a steroid long-term and they tell you it's for pain, you really should question that one. Because it is a very likelihood that they're going to, it's not that they will have issues long-term if we don't ask the right questions. But for short-term use, these are actually pretty decent options. And I threw that on here for completeness sake. I almost don't even want to talk about it. The completeness is about the fact that skeletal muscle relaxants exist. They really don't have much data, and especially in the older population. The data that we have is the side effects are way higher. Yes, it might depend on the agent with specific, individual side effects, but all of them will cause sedation and all of them will cause dizziness and drowsiness. I think you're catching onto a pattern here that pretty much most medicines that we use in pain management, dizziness, drowsiness, and sedation are listed as side effects, which are not good in an older patient. There's maybe a subset that could benefit from these muscle relaxants, but I'm not going to lie to you. I would really avoid them. And this is a personal preference. The guideline that I was reading said you really could consider it. And if you want my opinion, I would avoid them like the plague in older patients. Flexeril being and cyclobenzaprine being the biggest culprit here. If they happen to be used, you really just need to watch for side effects. These are, again, our medicines where I expect side effects. Is it worth it to be on this medicine? Hooray, your pain is fixed. But if you're so weak and overly sedated, again, is it worth it? To make sure we talk about it, the cannabinoids are, they're there. They are, in fact, beneficial in the older patients. Whether it be medicinal marijuana, whether it be cannabidiol or dronabinol, which I'll talk about in a little bit. The different type of cannabinoids that exist within marijuana, there's a whole bunch of them, but the 2 that we know the most about is THC and CBD. THC has all those effects that we think about when you think about drugs of use, the impaired judgment, impaired memory, coordination, sedation, the euphoria, paranoia. That's from THC. CBD has really minimal to no altered mental status changing proper to it whatsoever. The thing is, there's data that supports improvement in chronic pain with medicinal marijuana. What we really don't know is the effective dosing. And, I could sit back and say that, like, at the end of the day, from an older individual, going back to the concept, less is more, the lowest effective dose. We still don't even really have great guidance on that. But when you look at or at least a consistent guidance, how about that? The data shows that medicinal marijuana actually could benefit chronic pain. Don't inhale it, though, please. It's really the oral options. Now, CBD has mixed data in older adults. You know, there realistically might be benefit. What I can tell you is there really is none of those THC associated side effects. You really only might be sedated slightly. Not to say that it's better or worse, but you recognize that CBD is the one that really has this sedation and possible. You would like to think that it could help with pain. It's inconsistent. You know, there's inconsistent data on topical CBD versus oral. I would say that it's an option that you can always consider. Recognize that it may or may not be consistently effective. The other piece to add here is dronabinol. Now, dronabinol is synthetic lab-made THC. So you actually can think about it the same way you would think about the hallucinogenic negative properties of the marijuana, if you will. The problem is there's also data that does support dronabinol use in pain. When you look at the studies, it's not been in geriatric patients. So you maybe have to sit back and say, like, sure, there is some data in pain management for it, but in the older adult, it's scarce. The last three, step 3 options are your long-acting and other short-acting agents for opioids. Once you've reached step 3, severe pain, you almost always inevitably have to consider opioids. At least consider them. The other short-acting opioids that I have listed here, I didn't list them in the beginning because they tend to have more side effects. Or I shouldn't say that. They're more potent. They really should be avoided in opioid-naive patients. You kind of get somebody started on step 2 options, and then they might need to transition to these ones instead. Fentanyl, again, is always that scary thing that we hear about, in particular with some of the overdoses of heroin and whatnot. We use it in pain all the time. It is a very potent agent. It tends to be reserved more for cancer and palliative pain. That being said, it would be a step 3 option to consider in somebody who has severe pain, who's older. When in doubt, less is more. That's the motto. The long-acting opioids are when you really have a patient who is frequently using your short-acting opioid kind of almost around the clock. They really just need opioid all the time. You know, I'm not saying that, when you have a patient walk in, I could look and say, yep, I bet you're going to need a long-acting opioid. You don't start somebody on a long-acting opioid out the gate. You go through these previous steps if you can. You get to the point where you ensure that a patient truly needs a long-acting opioid. You get them started on a short-acting and transfer them over to a long-acting. I did want to point out that we do have methadone here. The caveat that I want to just share to everyone out here too is methadone is a very effective long-acting opioid. It should never be done by anyone unless they have some sort of training. I'll leave it at that. But please know that long-acting opioids are in fact an option in people who are older. It's making sure you have the right patient using the right dose at the right time. Okay, so again, pharmacology is my thing. So we talked about that a little bit more probably than what you all wanted to hear, but that was stressing the use of it effectively. Now, the other subgroup of individuals are those with severe cognitive impairment. Pain exists in people who have dementia. It's hard to treat it and it's hard to assess it. If you have somebody who is in fact verbal and can voice their pain, be as simple as possible in your assessment. Yes, no questions. Don't give them a lot of options, right? Make it as succinct as you can, if possible. Now, there is in fact a scale. It is called the Pain Assessment Advanced Dementia Scale. This scale is essentially tries to assess behaviors of an individual. So, for example, there's a question on grimacing and how does the patient's kind of look. There's questions in regards to how vocal are they and verbalizing some of just generalized noises, if you will. And when you score them, it comes out a score 0 through 10, which coincides with our number pain scale. So if somebody was doing a pain AD scale on a patient and it came out to a 6 out of 10, I would argue that that patient might have moderate pain based on the assessment of that scale, even though you didn't ask the patient any questions. When in doubt, non-pharmacologic options is the preferred option. Always will be. You're catching on to this. If you can't do it, and in particular, there is behavioral disturbances, you truthfully can assume they have pain and try to treat and see what happens. If the agitation doesn't get any better, it might not have been pain. So you don't have to continue the treatment. It's just agitation and behavioral disturbances might in fact be from pain not being expressed effectively. If we're going to do pharmacotherapy, Tylenol is the first one. Acetaminophen, pick it. The major difference, though, is it needs to be scheduled dosing. They need to get it 3 times a day. Like, don't make it as needed, because that requires a patient to verbalize their pain and tell you that they're in pain. If that doesn't work, try these topical options. You can consider an NSAID if you think it's localized. If you think it's neuropathic, your option would be Lyrica, the pregabalin, if you will. And you really could consider use of this long term if that appears to be the reason why they're in pain, if they're in pain and this worked, sure, you can consider it as long as you're not causing more issues. And there are 2 opioid options, and the real reason that the morphine and oxycodone are the preferred options in those with severe cognitive impairment is that it makes a liquid. There's a concentrated liquid that you can do a very minimal amount, less than 1 ml, get you the dose that you need. And you still need to monitor them effectively. When in doubt, avoid oral NSAIDs because there's data that suggests that possibly there's increased side effects that's just not worth it. So in severe cognitive impairment, it mimics, as you can see, some of the traditional pain. We're just limiting our options to the ones that may or may not be the most effective and most safe. I know I'm running out of time. I talk a lot. I'm going to do my best to try to summarize some of these last slides, and you have these slides for your own reference. If you're going to do short opioids for acute pain, because I want people leaving here not afraid or hating opioids, but respecting them. If you're going to use a short-acting pain, you should try to titrate as they're healing. If you're going to prescribe it, or it's going to be recommended, the lowest dose possible for the shortest, and in particular, the time that you think they're going to need for healing. If you think they're only going to need 5 days because that's how long it's going to heal, only give them 5 days. We measure opioids in clinical practice based off of like an equivalency of potency called the oral morphine equivalence. And I gave an example here of how to kind of consider the different quantity of opioid. If at the end of the day, a patient is taking more than 50 milligrams of oral morphine, you really need to question whether or not this is the right thing to do for a patient. And never use long-acting opioids in acute pain. When you're looking at chronic pain, I would rather you do a non-opioid if you can. As much as I like opioids from a pharmacologic perspective, I don't want you to use them unless you really need to. It's really only when quality of life and function is impacted in severe and moderate pain. Those frail adults, you got to be careful for, because I could fix your pain and I could cause you to fall. Was it worth it? If you're using another medicine class called a benzodiazepine, that's just a recipe for disaster when you're using an opioid along with it. If you can, assess for these related risks prior to and during the use. Like the respiratory depression is always our scare with opioids. So if they already have an increased risk for respiratory depression, it might not be worth it to really use an opioid, even though on paper it sounds like you should. If the risks outweigh the benefit, it is not worth it. You really need to assess for side effects for these. Constipation is a known side effect, as an FYI. And in older adults, constipation can actually lead to other issues that you would never have thought of, including mental status change. That could be from the opioid, and that could be, the mental status change from the opioid, or it could be the constipation from the opioid leading to mental status change. Some side effects can get better. The sedation might get better. I'm not saying it will, but it might improve. Some side effects will be present always, which is my spiel to you is make sure that anybody who is on an opioid has to be on a prophylactic bowel regimen, no question. They have earned Miralax. They have earned Senna daily if they are going to be on an opioid for an extended period of time. Do not use a stool softener by itself. The statement that I was taught, you can't have the mush without the push. The other thing that I want to point out, no matter what with opioids, more than likely you are going to develop tolerance to the dose for your pain. That does not mean you increase the dose. You can consider it. It's just if the pain level comes back if the risks of increasing the dose outweigh the benefit, that would be a good reason to not increase the opioid. Sure, you could increase it, but you could cause harm. My last few slides are really about understanding other resources that exist, in particular on opioid misuse. The evaluation of known risk factors, you really should check on this before an opioid is used or suggested. You know, if they have a history of drug use or substance use, there's a likelihood that opioids are maybe not a great choice for them. There are some assessment tools that you can use to try to guess what their misuse will be prior. There's the opioid risk tool. There's the screener for opioid assessment in patients with pain. Depending on their score will depend on their likelihood of misuse. And so then the question comes is, do I use an opioid long-term in these subgroup of individuals? I have to stress that opioids, and this is, again, this should sound very similar to what you would hear for younger adults because this is still paralleled with the older adults, right? There's a chance for misuse, and you should really consider naloxone in anybody who's using opioids, especially if it's going to be long-term. The thing is the education should be done to the patient, but realistically, naloxone is for the loved ones. You know, a patient is not going to be able to fix themselves if they're overdosing in very weird circumstances. I've listed a couple of resources below. Opie Rescue is an app, also a website, that can help guide you through whether or not somebody's having an opioid overdose. It can help you call 911. I know you panic. It's amazing how, like, I think the younger generation would pick an app before dialing 911. But it will help walk you through opioid overdoses and dial 911 for you. I'm in North Dakota, so I will plug the one program which was made in response to public health, trying to get at this opioid crisis, the Opioid and Naloxone Education Program. If you go to one-program.org, there's many resources used to help ensure that opioids are going to be used effectively and safely, and how to find naloxone. The last piece that you really could have just listened to me talk, realized that I talk fast, and just not actually get as much as you want out of this. When in doubt, leaving here, there's an entire website called geriatricpain.org, which their motto is it's a site for providing quality resources and tools for pain care in older adults. Clinicians, patients, family caregivers have access to free evidence-based pain assessments, tools, pain management strategies, and resources to identify and manage pain in older adults. It is a really cool website. It even has a list of questions that you, the patient, should ask a provider to make sure that they're being safely done. And frankly, maybe the pain is not getting managed. I don't want pain to be avoided. Pain management to be avoided in older adults. Pain exists. I want to make sure it's managed effectively and appropriately. And this is one site that realistically could make a big change for those people. In summary, pain is realistically across the board for everyone, including the geriatric patient. You really should prioritize non-pharmacologic options, even though I spent more time talking about the pharmacologic ones, because I want to make sure that we don't just throw a med at pain. But if you do throw a med at pain, you have to have a good reason. Most of our pain meds in the older individual have high side effects, and it's almost not always worth it. Assessment is very important. That's why I spent a long time trying to talk about the different ways to assess pain in the beginning. I gave a little bit more about talking about assessment at the end, because that is a hallmark to effective treatment in pain in adults with or without cognitive impairment. You really need to set goals. I want to stress that too, because if you don't have good goals in the beginning, you will never manage somebody's pain. And there are resources that exist for safe pain management that I'm hoping leaving here you guys will be able to reference, including my handout. Recognize this is it was based off of evidence. A lot of my data came from the Geriatric at Your Footprints handbook from the American Geriatric Society. Between my PowerPoint and those other references, I hope effective pain management can be had for your geriatric individuals.